Sorry, getting old. I missed this one. Hematocrit. In the placebo group, a lot of patients actually had, as they got older, they became borderline anemic. They actually had lower hemoglobin. On the testosterone and testosterone finasteride group, hematocrit went up. Now, this is, take it as standard that hematocrit will go up in testosterone replacement. It can be both a positive and negative. I'm hospital-based, right? I treat HIV patients. I treat end-stage renal failure patients. They have low hemoglobin. So for them, testosterone is fantastic. It reverses the sarcopenia, the muscle mass, and reverses the loss of hemoglobin. For your normal average male who's getting overweight, who snores a lot, who's got sleep apnea, who's a smoker, not a great thing. This is not polycythemia. So all your clinical evidence papers are based on polycythemia. Polycythemia means all 3 cell lines have gone up. Okay. Hematocrit is just hemoglobin going up. Okay, just take it as hemoglobin, simplified. So there are 2 schools of thought. One, if you go to high altitude, you go to Tibet, 5,000 meters, everybody's got high hematocrit. Okay? Deep sea divers, free divers, they have high hematocrit. Okay? And they seem to be fine. Last year, this is fairly new and I didn't put it up because I know the lead author on this paper. His name is Ramasamy, he's from the University of Miami. He published a paper on hematocrit, and it's new, it's 1 year, less than a year. He showed that hematocrit, in the first year, there was a slight increased risk of clots. In the first year, if your hematocrit crossed 54. But the effect was only in the first year. And it wasn't a big thing, it was a small thing. And the paper has a lot of detractors because Ramasamy is not fond of TRT. So, there's always that bias. How many of you all have attended Neil's course? Okay. Neil is very good. He is very good and I learned a lot from him. So Neil's view is it doesn't require treatment. My view, and this is my personal view, not evidence-based. Okay, everything else I'm telling you is evidence-based, but this is my personal view. One, cream has the lowest rise in hematocrit. So I tend to stick to creams or topical. Injections have higher, that's evidence-based. In the first year, I monitored the hematocrit very strictly. And if the patient is below 65, I encourage them to donate blood, 450 ml once in 6 months. This is my personal view. Older patients, like I said, I'm hospital-based, so easy for me. I get the anesthetist, we have blood bags to take out 450 ml once in 6 months. And then I monitor the iron level, transferrin levels, and ferritin levels to make sure the iron deficiency doesn't occur. This is a controversial point. A lot of people disagree with me. Some will agree with me. It is a little bit of, I'm going to be honest with you guys, it's a little bit of cover your ass. Okay, why I say CYA? You have a hematocrit, patient comes with 54. Bad luck, gets a clot. Your question is going to be like, you saw the patient with hematocrit of 54, you didn't do anything. Hard to answer, right? This is a practical cover your ass thing on my point of view. Whether you want to agree, disagree, personal choice. In my personal choice. But keeping a hemoglobin of 50, hematocrit of 50 is easy. Just venesection, 500 mils. And it is something I counsel all patients before starting TRT. Because almost inevitably you're going to get it. Now, interesting fact, almost all postmenopausal women have low hemoglobin. So for you guys who are postmenopausal, hey, good, hemoglobin goes up. For guys, as we get older, posterior pharynx becomes loose, right? Becomes saggy, your tongue falls back, you snore. You have sleep apnea, your hematocrit is already high. Check and see, check your patients with sleep apnea. A lot of them have high hematocrit. And they're metabolically obese. And now you added testosterone, hematocrit will go up, I guarantee it. So decide upfront what you want to do. If you're starting TRT, Know this answer before you start, because you are going to tell the patient before you start. You're going to tell them the hematocrit is most probably going to go up. For guys who are obese, big size, snorers, smokers, it will go up. What are you going to do? If the patient says nothing, I have no plans to do anything, I plan to do Ginkgo, okay, Ginkgo sort of works, document it. If the patient says, I'm open for venisections, good. Plan it out. Blood bank, by the way, blood bank does not accept hemoglobin above 17.5. The central blood bank does, all the others will not do venesection for hemoglobin above 17.5. So, two major centers for blood donation, Mid Valley and 1U, they both got blood donation. So, I counsel this as number one on every TRT patient, because it is the one thing you're going to see consistently across all randomized control trials, hematocrit rise. And if you do venisections too often, patient too aggressive, you're also going to get low iron. So be aware of that. Okay, clear or not? So key takeaway. On testosterone, your prostate will get bigger, PSA will go up a little bit, and hematocrit for sure as hell will go up. Okay? We good? Okay, so the 1 year Ramasamy paper showed no increased risk of embolism. So you type in Ranjit Ramasamy, hematocrit TRT, you get the paper. It's not a big paper, but it is one of the few papers that looked at specifically hematocrit in testosterone replacement, and it's a new paper. Because right now, the fastest rising prescription is testosterone replacement. It's a wonder drug for us, right? I show you further papers how good it is. But like I said, remember this, topical has a lower rise than injectables. And it depends on your patient profile, okay? So I love topicals for this. And topical is easy to control. All right. All right. Hold on, give me a second. I need a coffee for this. Okay. How do you all talk for 3 hours? Seriously, I talk for 30 minutes, I'm dying. Hey, so do I. I'm loaded to the gills with hormones. Okay, so those of you who never met me before, I think two of you all have seen me from last time TRT courses. I used to weigh 135 kilos, right? And balding quite a bit. I'm diabetic, hypertensive, high cholesterol. Heart's okay, surprising. I used to smoke. Okay, that's a lie. I still smoke occasionally. Okay. I don't drink, don't take drugs, snore like hell. Now my weight is 88. My waist size is 46 to, what am I, 36 I think. Something like that, 46, 36. Where's Elson? Okay, that's Elson. Elson's known me since 2013. He's my trainer, by the way. He also helps me out by taking videos because I'm too cheap to pay anybody else. Okay. So Elson's known me from 2013. Right? Train, diet, nothing worked. Because part of low T, I had very low T, my levels were 7, is you don't have the mental drive to go to the gym. Your testosterone high, you get up in the morning, you want to go to the gym. You sleep well, you want to go to the gym. Testosterone low, you sleep like shit, you feel crappy, you get up in the morning and you want to go back to bed. You think I want to get up and go to the gym and see Elson? He's not that good looking, I don't want to see him. So. Okay? So, as she said, I'm on testosterone. I'm also on thyroid hormone, but that's a different thing. But it's for my metabolic parameters. So on TRT, this is my personal story, I'm still progressing because I'm measuring my metabolic parameters are down. I do measure it. Symptomatically, I still haven't got to sleep right, so I still sleep 4 hours a day, so I got to fix that. But overall, you start to do better, okay? I want to say who else is on TRT, okay, but yeah, all right? But I still can't speak for 3 hours, though. All right, next one. All right, older men defined as 50 and above. Okay, who's on a 50 and above? That's me. Hey, come on. Thank God there's some few 50 and above. I'm starting to feel like I'm talking to kids. All right. Now, this is a subjective parameter which they've made it objective, right? Sexual activity. Don't ask me how they calculated this because it's such a subjective assessment. ability to walk distances, and vitality. Okay, what do they mean by vitality? Vitality is a general feel good, feel energetic kind of thing. They use questionnaires, so, but it's a good paper, and the main thing, see the top there, it says New England Journal of Medicine. Okay, NEJM, JAMA, Nature. Top 3, right, for medical journals. Well vetted. They have screwed up before, not that they haven't, but usually if I see a New England journal, quite good. And if you type in New England Cardiovascular Health with testosterone, you'll find a few more. There are just too many papers. This one was for us older guys. Subjectively, how well do we do with testosterone? Take a look. Okay? That's changed from baseline, That means how much improvement you got from your starting point. So, I have better sex life, I can walk better and feel better. How many of you want to go out and start testosterone right now? Okay. All right. Okay. So, for how many of you all downloaded the slides, by the way? Only one person. Shit, that's sad. Okay. Okay. Now, for the sake of it, let's pretend all of you downloaded the slides. The publications authors are here. Now, a shortcut for you all, if you all are too lazy to read the entire paper, take the paper, put it into ChatGPT, tell it to do 3 things. Tell it to tell you how the study is conducted, the shortfalls of the study, and the author's conclusion. You put these 3 things in, you get something decent, read the entire paper. Because the author's conclusion and real life conclusion, I'll show you later at the end, are 2 different things. For example, women's health got screwed by WHI because the author's conclusions and the headline news totally set women's health back by 20 years. Okay, because it just didn't add up, right? The epidemiological studies before the WHI were damn good, which is why they did the WHI, which is a $1 billion, US $1 billion largest women's health study, which totally set women's health back by 20 years. So always use ChatGPT to decide if you want to read the paper, and then read the paper. All right, easy. So, papers here, and this was the paper I showed you. This is another one. This is clinical and endocrinology. So it's actually an endocrine paper. And strangely, even though this is an endocrine paper, the Endocrine Association is still against testosterone replacement. And for those of you who work with specialists, be prepared, the endocrinologists do not like TRT. Right? So they looked at men who are more than 65. It's a small paper. Same thing. They gave, standard dosing for testosterone injections, right, is roughly 100 a week, right? Ballpark 100 a week. It's got a very short half-life, by the way. Testosterone is about 2 to 5 days. This is for simplicity. So testosterone finasteride, placebo group. Impressive thing, these guys are 65 years old. Anyone here 65, by the way? Or above 60? Really? Oh, shit. You look good, by the way. No, that came as a bit surprise. Who else is 65? Okay, 65. I can't give you a compliment I gave her. Okay? You guys are guys. So, I'm 54. If you tell me to increase my lean mass, right, by 4 kilos, no chance. Elson knows I'm struggling. If I can get it up by 500 grams, I'm already happy. This group got it up by 4 kilos. You know how much that is? That's a big chunk of your body weight. Okay, if you can increase your lean mass by 4 kilos, you're golden, above 65. Your risk of fall just went down. Your risk of bone loss just went down because good muscle mass, good training increases bone strength. Right? So, just to make sure there's a testosterone effect, they gave finasteride. Now, what happened to those who didn't do anything? Minus 200 grams. Okay? So, it is very, very hard for people above 50, I know most of you are not in the age group, to put on muscle. You can train and train and train. I mean, with testosterone boleh lah, but without testosterone, it's difficult as hell. On that caveat, testosterone works well if you train. So if you don't train, you still get some improvement, not much. You want the improvement, you have to train. Okay? As a urologist, I'm a big fan of resistance training for women and men. So all my women actually send to the gym. I know a few trainers who specialize in training older people, older guys, prevent injuries, prevent falls, and I focus on muscle mass. On the anti-aging index, the single biggest predictor of morbidity, not mortality, is your muscle mass for men and women. The single biggest predictor. You can look it up. Offhand, I can't remember the paper, but it's there somewhere. Okay, same thing. This is just, what do you call it? A visual parameter just to tell you. Okay, sorry, just now I spoke of this one, right? Muscle mass. This is fat loss. So what happens is, that group I told you put on 3 plus kilos of muscle, they also lost 3 plus kilos of fat. So if you weight them, they weigh the same. So if you use BMI, it's going to be confusing. But if you measure their lean fat and lean body mass and muscle mass, you can see the, lean mass and fat mass, you'll see the difference. If you did waist circumference, you'll see the difference. But if you just put them on the timbang, weigh them and did a BMI, you're going to have a problem because the BMI will still suck. Because BMI just shows weight. So almost the entire group, roughly equal fat loss and muscle gain. Okay? Alright. Okay. Tunggu sekejap. Questions. That's my break. No questions. Please, thank God, because somebody got questions. Okay. Okay. So, oral, there is no good oral available in Malaysia right now. The US has one sort of just launched, FDA approved. Oral has a negative effect on liver function, so we don't use it. Okay, in Malaysia, there is no good oral formulations that do not change hepatic function. Number one. So what's your question? Oral? Injection. Okay. Injection legally, and not from Thailand, not generic. Legally, you are down to Nebido. Nebido is testosterone underconate. You give it once in 10 to 12 weeks, and you give this massive bolus. It's 1,000 milligrams. Remember I told you all just now, a standard dose is like 100 a week. Now imagine I give you